Hi and hello everyone. In this video, we'll be discussing another topic in CNS, that is Parkinson disease. So, we'll be discussing the drugs for Parkinson disease. Now, let us start with understanding the Parkinson disease. You can see the man here with the mask-like face, slowing the movement, reduced arm swing, rigidity, freezing, tremors, postural instability, shuffling gaits. Now, what is the problem in Parkinson disease? The problem in Parkinson disease is there is decrease in dopamine. And in the brain, dopamine and acetylcholine are in balance. Now, what is the role of dopamine? The role of dopamine is to make movement, that is kinesia. The movements are guided with the help of acetylcholine. So, dopamine and acetylcholine are required for a proper movement. What happens in Parkinson's disease? What happens in Parkinson's is the dopamine decreases and there is increase in the activity of acetylcholine. Now, this is the pathophysiology. What happens in Parkinson's disease? Because of that, the person develops slow movement, because I told you dopamine is required for kinesia, and when there is less dopamine, bradykinesia means slow movement. Then he can develop tremors and rigidity. So these are the classical features what we see in Parkinson's disease. So as they age, the neurons worn off and the dopamine synthesis decreases and they develop Parkinson's disease. So if I want to treat, what is the aim of treatment? What should I do? Obviously, the dopamine is less, so increase the activity of dopamine. The primary aim is to increase the dopamine. Another aim is to decrease acetylcholine. So when we treat Parkinson's disease, the two aims are to increase the activity of dopamine and to decrease the acetylcholine activity. Now, first of all, let us do the first aim, increasing the activity of dopamine. Now, can I give dopamine orally? No. So the question is, can I give dopamine orally? No, because it will be metabolized by the enzymes MAO in the gut. Now, can I give dopamine injections? Will it cross the blood-brain barrier? No. Dopamine cannot cross the blood-brain barrier because it is metabolized by the MAO enzymes. So then how do I increase the activity of dopamine? For that, what we use is a drug by the name Levodopa. So Levodopa is given, and the Levodopa after metabolism will become dopamine. And this Levodopa is called as prodrug. The question is, why can't I give dopamine directly? Because dopamine cannot cross blood-brain barrier, but the Levodopa can enter the brain. So when the Levodopa enters the brain, in the brain it becomes dopamine, and this dopamine can act on two important receptors, D1 and D2. But in the brain, the most important thing I need to understand is the receptor, and the receptor is D2 receptor. So what happens when Levodopa enters the brain? I am writing. Please remember why I can give Levodopa, because it can cross the blood-brain barrier, and in the brain it becomes dopamine, and the dopamine acts on D2 receptor. Now this dopamine which is there in the brain can be metabolized by two enzymes, and the enzyme name is MAO-B. What is MAO? Stands for monoamino oxidase, and the subtype B. And another enzyme which can metabolize that is COMT. What is COMT? Catechol orthomethyl transferase. So now our goal is to increase the activity of dopamine inside the brain. What are the targets? So that I can increase it in the brain, particularly in substantia nigra. So number one, I can give levodopa, which will enter the brain and becomes dopamine. Second, what I can do is block the enzyme MAO-B, monoamino oxidase B. Or number 3, what I can do is block the enzyme COMT. So if I block the COMT enzyme or MAO-B, dopamine is not broken down, it will be there longer inside the brain. Then scientists thought what we can do, another thing is, why can't we directly stimulate the D2 receptor? Then we came with the 4 target, that is D2 receptor agonist. They are called as D2 receptor agonist. So there are 4 strategies to treat Parkinson's disease. Number 1, levodopa. Number 2, MAO-B inhibitors. Number 3, COMT inhibitor. And number 4, D2 agonist. Please remember, whatever drugs we are using for Parkinson's disease, they are not going to stop the disease progression. Then why are we giving these drugs? Is to treat the symptoms. And the most effective treatment among all these things is levodopa is the most effective treatment for Parkinson's disease. That was asked in one of the exams. Let us go one by one. Let us take the levodopa first. When I talk about levodopa, pharmacokinetics, the drug is very, very short acting. If you see the half-life of the drug, you can see it works for only 1 to 2 hours. Half-life is 1 to 2 hours. So the drug is taken 3 to 4 times a day. And even when we give the drug orally, it has high first pass metabolism. And yes, it crosses the blood-brain barrier, but the crossing is also very less. Why it is very less? Let us analyze that. The next thing what I am going to talk about, what happens when I give levodopa to a patient. When I give levodopa to a patient, levodopa gets absorbed and my target is levodopa should reach the brain. Levodopa reaches the brain. So this is the brain, or I can call it as the center. And this is the periphery. Now why I use levodopa? Because levodopa can cross the blood-brain barrier. So there is a barrier and that barrier can be crossed by levodopa. We know that. Now when I use levodopa, levodopa can become dopamine outside the brain also, that is in the periphery. If you remember dopamine can act on the receptors D1 at very low dose, beta 1 at medium dose, and alpha 1 at high dose. So the dopamine can activate D1, beta 1 and alpha 1. Now when it activates D1, it can cause low blood pressure, that is called as hypotension. But we increase the dose a bit, the heart rate may go up and that may lead to arrhythmia. Arrhythmias can be seen. Now if you still further increase the dose of levodopa, it becomes dopamine, and what you see is alpha 1 action, and that can increase BP. You may ask a question, sir, how come a drug can decrease the BP also, increase the BP also? That's the dose. Lower dose, very low dose, hypotension, high dose, hypertension. Now you know that alpha 1 action in the eye is mydriatic action. So because this alpha 1 can cause mydriasis, this levodopa is contraindicated in which glaucoma? It is contraindicated in angle closure glaucoma. Right, sir? Correct. Okay, sir. Now remember, dopamine, how much ever you give, dopamine can activate the receptor in CTZ, chemoreceptor trigger zone, and the patient will develop nausea and vomiting. At all the doses, the CTZ can be stimulated by the dopamine, particularly if you want to know the receptor is D2 and they develop nausea and vomiting. Okay, sir, that is fine, sir. Then who will convert levodopa to dopamine? The enzyme name is called decarboxylase. Now this decarboxylase, which is acting in the periphery, is called as peripheral decarboxylase. But the story doesn't end here. Levodopa has to work in the brain. Now this becomes dopamine in the brain also. So we require dopamine, correct. Particularly we require that in substantia nigra. But I cannot tell the dopamine, dear dopamine, go work only in that part of the brain. No, can work in other parts of the brain. It can go and work in other parts of the brain. So what happens if dopamine is excess? This can cause on long-term psychosis. So sometimes patients on levodopa, they can experience hallucination and all. That is called psychosis. Sir, is there any treatment for this? Yes, we can use atypical antipsychotics. Atypical antipsychotics. Sir, can you tell me some atypical antipsychotics? Clozapine, olanzapine, risperidone. Now recently there is a drug approved for that. The name is called pimavanserin. So pimavanserin is a drug used for Parkinson disease psychosis. Pimavanserin, as the name ends with serin, it has to do with something with 5-HT. So it's a 5-HT2 antagonist. And it starts with P, it is used for Parkinson disease psychosis. So dopamine excess can lead to psychosis. And who will convert levodopa to dopamine in the brain? It is called as the central decarboxylase. So the enzyme is called central decarboxylase. Now not only this problem, the second problem what we develop when we use dopamine for long period, the patient will develop abnormal movement, that is called dyskinesia. Dyskinesia. So this is happening inside the brain, please remember. So when dopamine is excess, that can lead to dyskinesia. You simply correlate that. The role of dopamine is kinesia, but when it is excess, it can lead to dyskinesia. Sir, is there any treatment for this? Yes, we have a drug called amantadine. The name of the drug is amantadine, that is used for the treatment. So if I use levodopa, what are the drawbacks? The drawbacks is the adverse effect. The BP may fluctuate, patient may have nausea, vomiting, patient may have arrhythmia, patient may have psychosis, and patient may have dyskinesia. These are the adverse effect. And one more problem is, if I use 100 drugs of levodopa, only 2 drugs enter the brain. Sir, what happened to 98 levodopa? 98 levodopa will be converted to dopamine outside the brain. So what happened? If less drug enters the brain, less efficacy. So that's why we thought, why can't we inhibit the conversion of levodopa to dopamine outside the brain? Then we came with a drug called carbidopa. Carbidopa and a drug called benserazide. So carbidopa and benserazide, they inhibit the enzyme peripheral decarboxylase. Again the question is, will they cross the blood-brain barrier? No. That is why we have them. If they cross the blood-brain barrier, they inhibit here also in the brain. And what is the use of giving levodopa with carbidopa? So the combination of levodopa and carbidopa makes more drug to enter the brain. So the drug can act longer, the efficacy increases. And not only that, the peripheral adverse effect, whatever we mentioned here, they can reduce. So that is the summary, what happens when we give levodopa to a patient with Parkinson disease, one of the beautiful drug levodopa. Now that's what we have written here. The less drug crosses blood-brain barrier. How to make more drug to cross blood-brain barrier is add carbidopa or benserazide. Okay. Now what are these peripheral decarboxylase inhibitors? I told you the name is called carbidopa and benserazide. So what we have done in next this thing is, what is the advantage of combining carbidopa and levodopa? The benefits, if I want to tell you the benefits, let me expand and write here. The benefits are there is increased levodopa delivery to the brain. So, more levodopa enters the brain. Second, the peripheral adverse effect decreases. The peripheral adverse effect, the arrhythmia, nausea and vomiting, the hypertension decreases. Then the combination decreases a phenomenon called off episodes. So, the off episodes decreases. So, the three advantages are more levodopa enters the brain, and there is reduced off episodes, and peripheral adverse effect decreases. Now, what problems are not resolved? Obviously, psychosis is not resolved. Then the next problem that is not resolved is dyskinesia if you combine these two things. And third problem, in KD Tripathi, he has given the postural hypertension problem. I told you this drug can cause hypertension. That problem is also not resolved by this combination. Theoretically, it should have been resolved, but practically the resolution is not seen. So, this is the combination of levodopa and carbidopa, the benefit and what problems are not solved. Now, I want to add one more point here. If you come back to this, there is a vitamin called vitamin B6. B6 is nothing but the vitamin called pyridoxine. Pyridoxine stimulates peripheral decarboxylase. Now, what happens if somebody takes levodopa and pyridoxine together? The efficacy of levodopa decreases because more levodopa becomes dopamine outside the brain. Usually, patient will not take like that. Suppose an elderly patient having Parkinson's disease is on levodopa, and he go to a general practitioner and tells, I am having tiredness. He will give multivitamin capsules. And multivitamin capsules contain the pyridoxine, and after some days the effect of levodopa decreases. Then the patient may develop the symptoms of Parkinson's disease, that is tremors, rigidity, bradykinesia may worsen. So, there is one interaction they can be asking you in the exams. Now, once we are done with levodopa, let us understand the drug interactions of levodopa. Levodopa and B6, just now I told you, they should not be given together. Levodopa and metoclopramide should not be given because metoclopramide is a D2 blocker. Now, we don't want to block D2 in a patient with Parkinson's disease, so metoclopramide should not be used. Levodopa should not be used with atypical antipsychotics because they also block D2. So, this is the drug interactions. Please have a look into this. Then coming to the contraindications of levodopa, they should not be used in angle closure glaucoma because they stimulate alpha 1, the pupil dilate, the angle closes and it will worsen. They should not be used in psychosis because dopamine itself causes psychosis. So, if you stimulate dopamine more and more, the psychosis worsens. And one more condition where we should not use levodopa in a patient with gastric ulcer. Moving on to, there are two phenomena called as wearing off on-off phenomenon. What happens in Parkinson's disease, I have told you repeatedly, this is a progressive disease. Now, the problem in Parkinson's disease is what happens in a nerve to nerve communication. The neurotransmitter has to be stored and whenever required, it has to be released. But here what happens in Parkinson's disease, the nerves lose the capacities to store the dopamine and release. So, that is called as wearing off. This will happen after 2 to 3 years of Parkinson's disease. Now, there are two phenomena you have to understand, on phenomenon and off phenomenon. What is it, sir? Now, the neurons have stopped having that capacity to store dopamine and release dopamine. What happens whenever I give levodopa? Levodopa can increase in the brain. That means it increases the dopamine. So, when you increase the dopamine activity, this is called on. The drug is on. Now, since levodopa is very short acting, the levels of levodopa comes down. And I am telling levodopa, I am telling as dopamine. The dopamine levels comes down and the patient has no drug, that is called off episodes. So, on means the drug is too excess in the brain. Why it is too excess? Because we don't have a storage mechanism. Suppose a water gushes inside. If I have a tank, I can store it, and whenever I have the time, I can take the water. But here what happens? Water will come at one time, and if I don't fill the bucket or if I don't fill my tanker, the water is gone. So this is what happens in on phenomenon. Suddenly when I give levodopa, the drug is on, and after some time the drug is off. On means drug is present, off means drug is absent. Now what happens if drug is on? The patient will experience dyskinesia. That means abnormal movements. So what is the treatment if the patient develops that? The treatment is amantadine. So if the patient is developing dyskinetic problem, then you can add amantadine. Off episode means drug is not there. Why drug is not there? I told you, nobody is there to store the drug, and levodopa is very short acting. So off episode means the patient has no dopamine in the brain, so he will develop the symptoms of Parkinson's disease. Now what are the symptoms of Parkinson's disease? You know, the tremors, rigidity, bradykinesia. Now there are two questions to be answered here. Now if the patient develops off episode acutely, suddenly, then what is the treatment? The treatment is by a drug called apomorphine. Now apomorphine stimulates dopamine receptor and it is given as subcutaneous infusion. Second is, in a Western population we have levodopa, which is given intranasal, that is given. Now the second strategy is, I don't want this to happen again and again. So I want to prevent off episodes. Now how do I prevent off episode? I know levodopa is short acting, that is why I am facing this. So make a drug levodopa sustained release. So it will release the levodopa slowly and dopamine levels will be there in the brain. Or what I can do is give a combination of levodopa with carbidopa, and that is what we wrote. Combination of levodopa, carbidopa reduces off episodes. The other strategies are use MAO-B inhibitors. So if I inhibit MAO-B, the dopamine levels will be more. Or I can do something COMT inhibitors, or I can stimulate the D2 agonist can be used. So these are the strategies to prevent off episodes. So that is in detail the dopamine, levodopa, what is the pharmacology of that. So once we are done with that, let us go to the other targets. The target number 2, that is called the MAO-B inhibitors. How do I remember MAO-B inhibitors? They end with gilin. They end with gilin. The name is selegelin, rasagelin. Selegelin and rasagelin. And recently we have a drug by the name safinamide. The name is safinamide. These are MAO-B inhibitors. Then let us move on to the next target. They are called as COMT inhibitors. COMT inhibitors, they end with capone, capone, capone. Entacapone, tolcapone, opicapone. So opicapone is a recent drug. Tolcapone is not used nowadays because of hepatotoxic problem. So the drug is toxic to the liver, hepatotoxic. So it is not used. So what is available now is entacapone and opicapone. Yes, we are done with the third target. What is the fourth target then? The fourth target is stimulate the D2 receptor. They are called as D2 agonist. There are two types, the ergot derived and non-ergot derived. The ergot derived the drugs are bromocriptine, cabergoline, and old drug pergolide. But the problem with ergot derived drugs are they can produce certain adverse effect, that is they can cause fibrosis, particularly the peritoneal fibrosis, that is retroperitoneal fibrosis, then pericardial fibrosis. So that is a problem when you use them for a very long period. Second, since they are derived from ergot, they can cause vasoconstriction, and that becomes difficult to use it in cardiovascular diseases. So that is why the discovery started coming with non-ergot derived D2 agonist. The name is Prami. Then we have Roti and then Ropi. So the names are Prami, Roti, Ropi. So remember, Ropi has no role in this. Simply to remember the drug, Ropi, no role. I got the Roti, so it is called as Roti gotten. And if I get the Roti, I am perplexed. Prami, Pexol. So at least remember the names have Prami, Roti, Ropi in the name. Now Roti कैसे होता है? गोल गोल होता है. So Roti is available as patch. Roti gotin is available as the skin patch or transdermal patch. But the problem with the patch is sometimes the drug forms crystals in these patches. Now, apart from Parkinson disease, these non-ergot deriveds, they are also used to manage one more condition. The condition is called restless leg syndrome. So they are used in management of restless leg syndrome. So usually nowadays, what is the drug of choice if they ask you? The gabapentinoids like gabapentin, pregabalin. So these are the first choice for chronic restless leg syndrome. If that is not there, then you can use non-ergot D2 agonist. And what are they, sir? They are nothing but Prami, Ropi, Roti drugs. So until now what I told you, they are all to increase the dopamine activity. Let us revise again. Number 1, levodopa. MAO-B inhibitors end with gilin. COMT inhibitors end with capone. And D2 agonist, ergot, non-ergot. Non-ergot, Prami, Roti, Ropi. And what is the drug of choice for restless leg syndrome nowadays? Gabapentin. Now, once we know that the first aim is achieved to increase the dopamine, what is the second aim? Is to decrease the activity of acetylcholine in the brain, and they are called as central anticholinergics. Now, what are these drugs? The drugs have bens in the name, benztropine, benzhexol. Now, if benz and atropine marry, they become benztropine. Benzhexol, hex has one more name. The name is called trihexyphenidyl. Many a times this examiner wants to test you. So remember, if there is hex in the name, they are both the same. Benzhexol, trihexyphenidyl are same. How many bens are there? 2. What is the other name for 2? Bi. Bi means 2. If you have 2 bens, you can take the bens every day. So bi, peri, den. Every din you can take it. Biperidin. And if you are bored with Benzgar, you can take the cycle. You can take the cycle to the office. That is called procyclidin. Take it every day. If you are bored with biperidin, procyclidin. Okay, so please remember that. And promethazine is also sometimes used because this is a first generation antihistamine. Now, if it is an antihistamine, why are we using it? Remember, first generation antihistamines also have anticholinergic property, and promethazine has high anticholinergic property. That's why. Okay, sir, target achieved. But we have another drug by the name amantadine. Actually, amantadine had a role in influenza, but nowadays we have best drugs for influenza called oseltamivir. Now we don't use it for. It was used for influenza A. Now the specialty of amantadine is it's a dopamine facilitator, so which will help in overcoming Parkinson's symptoms. Second, it will not allow the dyskinesia to happen. It is having anti-dyskinetic property, and it has shown to produce anticholinergic property also. Anticholinergic property, and it can block NMDA receptor. So if you don't want all this to remember, at least remember it has anti-dyskinetic property. But two classical adverse effects that has been shown with amantadine, which can be asked in the exam, is one is it can produce the edema of the ankle edema, and it can produce a network of blood vessel. It is called as livedo reticularis. Particularly this network of blood vessel is seen on the skin. I will show you that image in the next slide. So the name is amantadine. You can see this network of blood vessels. This is what we mean by livedo reticularis, and the drug is called amantadine. Right, so that is about drugs for Parkinson's disease, a very small topic but high yielding. So we'll take up some high yield points. Now before that, is there any new drug? Yes, we have a new drug in Parkinson's disease. It is called as estradiol. Usually drugs ending with phylline or phylline, they are something to do with adenosine. Now this is a adenosine antagonist. And what is the approval for this? What is the condition it will improve? It has shown to improve off episodes. So it is used to prevent off episodes that happens in Parkinson's disease patients. So that is estradiol. Now let us take up some high yield points here and just tell me the answers. Safenamide, a new drug in Parkinson's disease, साफ कर देता है. Safenamide is a MAO-B inhibitor. Sir, you told MAO-B inhibitors end with giline. Yes, but this is a separate drug. Please remember that. Drug of choice for restless leg syndrome. The name is gabapentin. If it is not there in the option, what will you choose? Non-ergot D2 agonist. The name is pramiropiroti. MAO-B inhibitor available as transdermal patch. Remember, it is selagelin. Add this to your notes. Selagelin transdermal patch is not for Parkinson's disease, it is for depression patients. So this point you have to add in your notes. I think the same question has been repeated here. Moving on to certain reasoning or analytical skill. Let us take up that. Levodopa, not dopamine, is used in Parkinson's disease. Why? The reason is dopamine cannot cross blood-brain barrier, so I have to use levodopa. Levodopa is a fixed dose combination with peripheral decarboxylase inhibitor. I told you, levodopa is given with carbidopa. The advantage is more drug enters the brain, so efficacy increases. There is reduction in peripheral adverse effect, and there is decrease in off episodes. Pyridoxine abolished the therapeutic effect of levodopa. Yes, in the periphery, levodopa will become dopamine with the help of peripheral decarboxylase that is activated by pyridoxine. So if I use pyridoxine and levodopa together, the efficacy of levodopa decreases. Central anticholinergics benefit patient with drug-induced Parkinson's disease. Now sometimes what happens, Parkinson's disease can happen by the aging process. Sometimes what happens, if I block D2 receptor, after some days the drugs can also cause Parkinson's disease. For example, D2 blocker drugs are typical antipsychotics like haloperidol. Haloperidol is a typical antipsychotic. Let me write it fully. So if I use it for 2 to 3 months or 1 or 2 months, the D2 receptors are blocked, so acetylcholine goes up. And what happens? The patient develops Parkinson's disease. So it is because of the drug he is developing. That's why it is called drug-induced Parkinson's disease. So what should I do? Dopamine is blocked, acetylcholine is more. Should I stimulate dopamine? No. Problem is, if I stimulate dopamine, dopamine causes psychosis. So what should I do? I have to decrease acetylcholine. And who will decrease acetylcholine? The central anticholinergics. Clear? Yes. Then coming to the MCQs, levodopa and carbidopa combination doesn't reduce which of the following side effect? 100% the side effect that is not reduced is psychosis and dyskinesia. Vomiting will stop, arrhythmia will stop, off episodes will stop when you combine them. Coming to the next question, which of the following is approved for both Parkinson's disease also and restless leg syndrome also? Selagelin is a MAOB inhibitor. You can use it in Parkinson also, depression also. Levodopa is only for Parkinson's disease. Now, pramipexole is a D2 agonist. It's a non-ergot which is used for both Parkinson and restless leg syndrome. Now, cabergoline is a ergot D2 agonist which is used for Parkinson's disease, but it is not used for restless leg syndrome. So, the answer will be C. Which of the following medicine is used for treatment of hallucination and delusions associated with Parkinson's disease psychosis? I told you this drug, there may be Parkinson's disease psychosis, patient will have hallucination and delusion. The name starts with P. Pimavanserin is the drug which we use. And amantadine is used to manage dyskinesia. And apomorphine IV or subcutaneous can be used when there is sudden onset of off episodes. Even levodopa intranasal can be given when there is sudden off episodes. Then the last question, NEET-PG. A female developed pain and inicet crawling like sensation on legs at night, which is relieved by shaking her legs. What is the drug of choice here? The drug of choice, before I go to that, what is the problem? Pain, insect crawling like sensation at night, shaking the legs is restless leg syndrome. Nowadays, the drug of choice is gabapentin. So that is the answer for this. So with that, we are done with drugs for Parkinson's disease. Happy learning. Best wishes. Thank you all.